Intrapartum osteopathic manipulative treatment, a non-invasive method for enhancing labor and delivery. The use of osteopathic manipulative treatment during pregnancy has a long tradition in osteopathic medicine dating back to the earliest days of the profession. There is evidence that OMT during both the prenatal and postnatal period improves outcomes for both mother and baby. Current research has primarily focused on the effects of OMT in reducing pregnancy-related back pain, improving autonomic and hemodynamic control during pregnancy, and restoring function after delivery. While there is active research examining the applications for both prenatal and postnatal OMT, few researchers have investigated the benefits of intrapartum OMT provided during labor and delivery. If intrapartum OMT improves labor outcomes, it may revise the standard of care in managing women in labor. The aim of this literature review is to identify current research investigating the use of osteopathic manipulative treatment during the intrapartum period. We aim to better understand if intrapartum OMT can be utilized to enhance or augment the course of labor and delivery. We hypothesize that in addition to standard management of labor, providing OMT during the intrapartum period may help to eliminate somatic dysfunction and facilitate the body's natural labor process, reduce pain associated with labor and delivery, shorten the length of labor, and reduce the need for medically or surgically assisted deliveries, including cesarean sections. A comprehensive literature search of peer-reviewed journals and articles using the databases PubMed, Access Medicine, the Cochrane Library, Dynamed, and the Journal of American Osteopathic Association was performed based on a wide range of key search terms, including OMT, OMM, labor, delivery, intrapartum, pregnancy, and augmentation. Only English language studies of subjects in labor stages 1, 2, or 3 from the past 100 years were included in the search. No studies were found examining the use of OMT during the third stage of labor. We identified 12 studies investigating the use of intrapartum OMT during the first and second stages of labor. Two authors independently extracted data from the 12 studies selected for review, which were assessed for quality of evidence using the GRADE framework. Overall, we determined there to be low quality evidence for study outcomes due to substantial limitations in research. We identified 12 studies investigating the use of intrapartum OMT during the first and second stages of labor. No studies were found examining the use of OMT during the third stage of labor. Current objectives in intrapartum OMT research include: can intrapartum OMT shorten labor, reduce labor pain, reduce the rates of cesarean section, reduce episiotomies and vaginal tears, facilitate natural birth without the need for narcotics, initiate uterine contractions, prevent uterine rupture with repeated cesarean in women undergoing TOLAC? In the 12 studies reviewed, we found low-quality evidence suggesting that intrapartum OMT does enhance or augment the course of labor. Our results demonstrate that the use of intrapartum OMT provided during labor significantly shortened the labor duration, decreased the use of pain medication during labor, reduced episiotomy rates in primiparous women receiving intrapartum OMT, reduced the rates of vaginal tears, and reduced the rates of cesarean deliveries among healthy women receiving intrapartum OMT. Other notable findings that did not reach statistical significance demonstrate that osteopathic CV4 cranial manipulation may be effective in initiating uterine contractions. Women receiving intrapartum OMT treatment subjectively reported a considerable reduction in pain during labor. Intrapartum OMT was used to facilitate a successful VBAC in a patient undergoing trial of labor after cesarean. Additionally, intrapartum OMT was associated with umbilical pH levels of less than 7.35 in newborns and with higher APGAR 1-minute and 5-minute scores in newborns. Research is limited due to underpowered studies with small sample sizes, which may overestimate true effects and limit reproducibility. In the studies reviewed, outcomes were not always evaluated after adjusting for variables such as gravida, parity, maternal age, maternal weight, birth weight, race, or ethnicity. In some studies, women received epidurals or pain medication and oxytocin for labor augmentation, which limits conclusions to that cohort only. Among the studies identified, there was variance among study protocol, including OMT techniques used and length of treatment provided, as well as provider variability, including the type of provider administering the protocol and their level of experience providing the treatment. Among the randomized control trials, which utilized a control group, it was unclear how controls were selected, and these studies did not provide a clear description of the sham treatment provided. In addition, current research is limited due to variance in prenatal care, as some women received OMT throughout their pregnancy leading up to labor, which may influence the perceived effects of intrapartum OMT treatment. While OMT is rarely used during the intrapartum period, our findings suggest that there are several applications for its use in effectively enhancing labor and delivery. Providing OMT during the intrapartum period may eliminate somatic dysfunction and facilitate the body's natural labor process, reduce pain associated with labor and delivery, serving as an alternative option to pain medication and epidural in women who desire a natural childbirth, lead to less medically or surgically assisted deliveries, shorten labor duration, and reduce the rates of episiotomies and vaginal tears. Our results show that intrapartum OMT has the potential to improve labor outcomes, which demonstrates exciting possibilities for osteopathic physicians who desire to provide non-invasive approaches for their obstetric patients in active labor. Further investigation of the effects of intrapartum OMT that build on the current evidence is warranted. Future research would benefit by addressing randomization, sample size, and study power so that more definitive conclusions can be made. We recommend further investigation of the use of intrapartum OMT during the second and third stage of labor, applications for CV4 cranial techniques during labor to initiate contractions and reduce the need of other forms of labor augmentation, and further assessment of the implications for intrapartum OMT to manage labor pain with standardization of pain measurement to limit the variability. Thank you.